The next case is a 25-year-old female. She was diagnosed with dextroposition of heart in infancy, and recently she developed class 2 NYHA dyspnea and chest pain. Initial echo was showing dilated pulmonary arteries, and she has never undergone any surgeries. She is a well-built lady with 70 kg. On her clinical examination, there is elevated JVP, but there is no tachycardia or tachypnea. She is having dextrocardia, and there is a right parasternal impulse. There is also a to and fro murmur for her. And this is her ECG, which is showing normal sinus rhythm with a PR interval of 180, QRS axis 90, and there are features of RV volume overload. This is her chest X-ray, which is showing cytosolitis, dextrocardia, with a CTR or cardiothoracic ratio of 60%, and we can also see that the arch is left. This is her thoracic echo, which is showing cytosolitis with dextroposition of the heart. There is mild TR with RVSP of 30 plus RA, and the RA-RV, as you can see, is dilated, and there is borderline RV dysfunction. In the next image, you can see that the MPA and the branch PAs are dilated, and there is significant PR. The PR Doppler signal is also shown. This is the CT of the patient, which is showing that most of the cardiac mass is on the right side, and the RV is in a more horizontal plane, and here is a very dilated pulmonary trunk. The pulmonary trunk is measuring 48 millimeter. It is dilated. And the narrowest area is also shown, which is measuring around 36 millimeter. We also did an MRI for her, which showed borderline RV function. There was early RV dysfunction with an RV EF of 48%. The regurgitant fraction was 65%. Here are the angiographic images in which we can see that there is a dilated RVOT with a dilated pulmonary trunk. It's another image which is showing the same. And here we measured the narrowest portion, which is measuring around 32 millimeters. Here we have balloon interrogated the RVOT, and we can see that the narrowest portion is measuring 32 millimeters with the balloon, and also we can see that the coronaries are not being compressed when we are balloon interrogating the RVOT. This is a 3D volume rendering of the 3D of the CT of the patient. Here we can see that the most of the cardiac mass is on the right side, and the RV is more horizontal and more anterior, and the RVOT is dilated. Pulmonary arteries are also dilated. This is a section showing the RVOT and the MPA and the branch PAs. Here we can see that there is an aneurysmally dilated MPA, and the branch PAs are also dilated. Here we are virtually placing a pulmonary valve. We are virtually trying to implant a pulmonary valve, venous P3630 valve, onto the RVOT, and now we can see this happening in our lab.
So, Mario, can you hear me?
Yes, we can hear you.
Okay, Alison, this is an interesting patient, Alison. There is no previous cardiac surgery, but there is an idiopathic dilatation of pulmonary regurgitation with free severe pulmonary regurgitation. Regurgitant fraction is more than 65%, almost 2/3 of the cardiac output is reflexing back into the right ventricle, and the patient is increasingly becoming symptomatic. She's planning to soon get married and like start her family, and so multiple considerations fell in place. Like there was a onset of RV dysfunction on the MRI with ejection fractions falling down. The pulmonary regurgitation fraction was more than 65%. The patient was increasingly becoming symptomatic and is having a possibility of an impending pregnancy in near future. So we decided to go for a valve implantation. Dr. Pramod, who is my colleague here, he is the person who did the virtual reality reconstructions on the Vimencio platform. He basically dissects out the heart. He discusses a lot with Adam Kolesnik from Poland, and he gets the virtual valve implantation. The balloon size was 32 millimeter, and so we normally go for about +4. So we decided to go for a 36 millimeter. The main pulmonary artery was very large and very roomy, so we decided to go for the longer valve. And so our plan is to go for a 36-30 venous P valve. And now what I will now show you is the angiography. Show the first picture. So this is the first angiography that we did today. So this shows this is, I pointed out previously in the PowerPoint, this is a patient who is having a dextroposed heart. So this dextroposed heart is making the right ventricle come on the right side of the sternum and the main pulmonary artery come on the left side of the sternum. And so this is almost in a very shallow LAO cranial view. We are able to open out the outflow tract, and we are able to see that the expansile right ventricular outflow tract, it also measured about 32 millimeters with the marker pigtail. We have a Lundquist wire that is placed within the left pulmonary artery. Any questions, Alison? I think Mario has got far more experience of usage of this venous P valve. Mario?
Well, I think that's a very challenging case because of a huge dilatation on the main PA. I think provided you can put a valve in, I think there is no way that the stent will be in contact with the wall in the main PA. And I wonder if your intention is to put a valve partially straddling the more restricted point and the RV to PA junction, or what?
Yeah,
I think that's the only position where the anatomy can hold the device in place. You agree with that?
I agree, Mario. In fact, our plan is to put the platinum markers, the proximal platinum markers of the valve at the ventriculopulmonary junction, and keep the majority of the valve on the dilated main pulmonary artery and form the flare on the confluence. Actually, if you look at the image, the pulmonary artery is very huge. It measures about 48 millimeters on the CT scan. However, it is very expansile. I wonder, you can start rotating.
Siva,
yes?
Hi. Just a quick, how often do you see such idiopathic dilatation of the pulmonary artery needing valve intervention?
This is the first one, Eric, that we are doing because the patient is having a regurgitant fraction of about 66.
No, I understand it, but it really seems unusual.
Yeah,
I've got Warwickon and CC here who've probably put in a lot of P valves. Let's get some comments from them.
Shiva, actually I came late, sorry for that, but it's quite challenging, huh? And Cici is sitting with me, by the way. So the plan, I totally agree with Mario that we probably will go to the long waist, which will hold the valve. So I do agree with you. I'm not sure about the size because I didn't come early. But 30, 32 should be a reasonable one. The challenge will be, we may try to open more flare, distal flare, a bit more distal, and then we try to pull back. That will give us a room for, moving downward. So that's probably will be my thought at the moment.
Okay.
Sisi, any comments?
Warakan, since you came late, I will tell you some of the dimensions. The balloon sizing was 32 millimeter. The angiographic size was also 32 millimeter. So we decided to go for a 36 by 30.
32, balloon interrogation. Well, that's mean probably this is because it's not the native, this is not the post-top repair, so that's why it's not expand side too much, maybe because of the ring is a bit more rigid. So you go for 36, right?
Yeah, the balloon
36
sizing
should be okay. But a bit
15 at
oversizing
50.
to be, but anything, I think it's fine.
The balloon size, the balloon stretched diameter was 32 to 33, and so we have quite deep inside, no, Pramod? It's quite deep. So I'm loosening out a little bit. Yeah, you keep Yeah, keep releasing.
And Shiva, is that a dry seal you've got?
No, this is a cook sheath. On one
I
second. One
can't
second.
see. I can't
It's
see the dry seal.
it's a cook sheath. It's a long. I will now show you another 15 at 15. Uh, it's a cook sheath that is now just across the tricuspid valve into the right ventricle, but just proximal to the. Yeah, keep inflating.
Well, I think that the size of the main PA is so huge that I suspect the flare, the distal flare, will be fully open in the main PA actually without having a contact. Yeah?
Yeah,
Because
I'm
the
good.
36 means that
Stay there. Now show me.
46
Get me
complete size.
20 at 18. 20 at 18. Ready? We are still deeper. So now, Varakan, what do you say? Basically, you can see that the. Can you move the table a little away from me? Yeah. So now.
So you're still deep.
Yeah, we are still deep. We are still deep, and let us come up to the valve. Pramod, you come up to the. Be very slow now.
Yes, Warakan.
Shiva, so if I were you now, I probably may not open more.
Yeah.
But we'll pull back until we
Okay.
are close
Ready?
to the waist.
Okay.
Yeah.
So
Yeah,
now-
yet you have to go back significantly.
Yeah.
Okay. Now, get ready. Another injection. Go a little up. Yeah. Ready?
Just a quick question. Whilst you're doing the angios, do you wait for the valve to warm up so it expands to its full size, or?
Yeah, it's expanding, Salim. It's becoming larger. Yeah, like couple of rotations, still you come to the platinum marker. That's enough.
Shiva,
That's enough.
I think we can come back more.
Okay. Let me make another angiogram. I think I'm happy here, Pramod. Varakan, Tejasvi, can you get it injection? Now, see the picture now.
Well, Shiva, may I say something on this?
Yeah.
For me, worst case scenario will be somehow if the proximal flare is not catching the waist, and then it will fly distally. If I could, I probably would pull a little bit more and try to make sure that the proximal marker is somehow a little bit, maybe a few more millimeters down to the RV. And perhaps at this moment, we may pull back the cook sheet a bit because that may ease up the curve, and then, something maybe more understanding in terms of anatomy before we release.
Okay, actually, as I pulled out, the valve got released a little bit more also. Now we are just waiting for loading the injector. Yeah, set 25 at 18. 25 ml at 18 rate. Ready? What do you say, Varakan?
I think you cannot pull back more, because it's catching the waist now. And the blood pressure perhaps maybe a little bit compromised.
Blood pressure is stable right now.
Okay.
What I will do is I will maintain a forward pull as
Yeah.
Pramod is releasing. Pramod, keep releasing. Yeah.
Mario, you happy with that?
Yeah.
Mario.
Keep releasing. Yeah. Release. successfully released. Now we have to see whether the eye is catching. Fluoro store that and playback. Fluoro store. Okay. Now can you show the wire position is coming off? So can you hold it? Like I'll just advance the wire a little bit inside. Yeah, that's enough. Now show the previous fluoro store. Yeah, this is the release sequence. Get ready for 25 to 18. The moment this release is completed, this is actually a stored fluoro Varakan. This is not live.
Yeah.
So it looks very stable. Are you happy with the position?
I think so, Alison. Now I'm making one angiography. Position it. Actually, my catheter is to some extent in the right ventricular side. I will take it out later, but I will make one angiogram. Shoot. Okay. The valve seems to be in a good position. I will now.
It is indeed, yes.
I will now wiggle
Very
out
good.
the thermo wire. I will wiggle out first the pigtail catheter, which has got trapped between the valve and the wall of the right ventricle.
That would be nice. Maybe inserting a wire into the pigtail.
I'm inserting a thermo wire.
Sorry for saying that.
I'm introducing that pigtail into the pulmonary artery now.
Yeah.
Do you see, not being a venous operator, do you see any challenges removing the carrot through this valve with that angle, or should it be pretty simple?
I wish it goes simple, Alison. There were times at which there were some difficulties faced. Let me try it out. Now, what I'm going to do now is make an angiogram of the distal part. Ready? The valve looks fine to me. Now, as Alison, you pointed out, that the challenge is only to take out the carrot securely. Pramod, you come and control here.
Looks very nice, Siva. Congratulations. Very, very nice.
This is a very dextroposed heart, Mario. Come to AP view. Okay. Now show the lower part of the. Yeah. So now I am locking the sheath. Show the valve above. I have got the valve inside my 24 French long cook sheath. We don't get the Gore dry seal in our country, so we use the 24 French cook sheets.
Yeah, you mean a short one?
No, this is the long one, Mario. In fact,
A long 24
French.
cook sheath.
yeah.
That should be an alternative to the 26 dry seal sheet that most people are using.
Correct. Now what I will do is I will try to take out the. I want a Judkins right coronary catheter. Yeah, I will take out my Lunderquist wire safely out of the scene. Get ready, 30 ml at 18 rate. One angiogram. Brother, come here. Control. You leave this. You can. You are controlling the wire there? Yes? So now I'm just planning to take out my Lunderquist wire. So I'm going to make a pullback from the right ventricle, from the pulmonary artery into the right ventricle. Connect both to pressures, 25 scale.
So this will be a very beautiful result, something you make look very easy.
I hope so. See, now both are pulmonary artery, both the catheters in the pulmonary artery. I'm going to withdraw my right coronary artery catheter proximal to the valve. So that is the, increase the speed. So there is a good hold up of the diastolic pressures. Take away the mean pressure from the right ventricle. No mean pressure for right ventricle.
So then another quick question on your anticoagulation regimen, since you said she would desire to become pregnant, but do you use short-term dual agent, or what did you do after your
we
venous
give
valve?
dual antiplatelets. We give aspirin plus Plavix. We don't give Coumadin. Little bit RAO. No, little bit LAO. Sorry, LAO. A little bit more LAO. That's enough. I want the valve to be in profile. I'll slightly come out. Little more cranial. You will do the figure of 8. Okay. So now we are ready for the final angiogram. Take away that filters. So we don't give Coumadin, we give aspirin and Plavix, and in case if she becomes pregnant, I will probably continue aspirin and stop her clopidogrel till she completes her pregnancy, and then again go back to aspirin plus Plavix.
That looks beautiful.
Very good.
So,
A big applause
Very nice.
to Siva.
so now Dr. Pramod will now take the figure of 8 and complete this case. We have another interesting case that is going on in the other cath lab. So we'll just move to the other lab. Can the presenter give the PowerPoint presentation?
Okay, Siva, run
Thank
to the
you.
other cath lab.